Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today, again, in our Conversations with Cancer Experts series, we have the pleasure of hosting Dr. Danielle Brander, who's Associate Professor of Medicine and Director of the CLL and Lymphoma Research Program at Duke Cancer Institute, premier institute, and she's one of the leading figures in the area, and we're glad to have her. And we're going to talk about evolving concepts in CLL, MRD, with a focus on measurable residual disease. Welcome, Danielle.
Well, thank you. Thank you again for having me.
So, Danielle, can you tell us before we launch into the role of MRD assessment today in management of CLL, how do we measure MRD?
Absolutely. So in CLL, a couple kind of high level points I'll just make is first, while MRD is becoming increasingly important within our trials and with certain patient circumstances, it's certainly not quite yet prime time, a standard of care for all. The second point just to make is that really we use this data for certain patients with certain therapies. So we'll talk about it with chemoimmunotherapy and venetoclax regimens, but just making sure that understand it doesn't apply to, thinking about all treatments, for example, BTK inhibitors, which are still very effective. Over the years, in terms of MRD methods, as you've nicely outlined, certainly these methods have, as technologies have grown, there are different methods to measure them. And what MRD or measurable residual disease really is, the thresholds for defining them as the methods have gotten more advanced, the sensitivity has. I would say generally it's still accepted that undetectable MRD is if there's less than 1 in 10,000 or 0.01 or 10 to the -4th. And so to do that, many flow-based or flow cytometry methods, either in-house, sometimes SendOut can do that. But the next generation and other sequencing assays, which are available, are able to get down to deeper levels, like 10 to the -6th, for example. For the most part, many of the trials, the gold standard still is checking MRD in the bone marrow. Although many of the studies are, and clinical practice, importantly, pairing it with peripheral blood testing as well, because ideally, I think for this to be feasible to more patients, of course, doing multiple bone marrow biopsies for patients is not desirable or feasible.
So can you just broadly tell us how we have advanced in our treatment paradigm for CLL, and then we'll put in context how MRD has played a role in these various time frames?
Absolutely. So as you have outlined in the recent decade, I would say, really have evolved both for patients previously treated and those as first treatment, moved away from chemoimmunotherapy now to the targeted drugs. And that's namely because there's multiple randomized phase 3 studies showing the benefit of the targeted drugs. So that being said, we individualize to patients. I'm sure there are still some acute settings where patients receive chemo, but most patients these days now are receiving targeted drugs. The main two classes of targeted drugs that we use for CLL are the BTK inhibitors, first and second generation, and now we have non-covalent BTK. And then the approved BCL2 inhibitor is venetoclax, which as a first treatment is paired with the antibody obinutuzumab, and the relapse refractory was approved with rituximab, though we also use it with obinutuzumab in the relapse setting as well. And then lastly, to your point, we're now having patients that are double exposed or double refractory to these effective targeted therapies. Most recently, CAR-T was approved in CLL. I think clinical trials are still very important to have for patients, especially that have been exposed to both BTK and BCL2.
So it seems that MRD is not a new concept, and we've had data from even the chemoimmunotherapy era. So can you give us just a general idea of how we did in that era as far as MRD went?
Yes, absolutely. So I think as it was recognized with chemoimmunotherapy, and as you outlined, the previous to the targeted therapies, the primary gold standard, so to speak, chemo regimens we were using was FCR for younger and fit patients, and bendamustine rituximab for older patients, or obinutuzumab and chlorambucil for some patients, not so much anymore. But in recognizing that, some patients had these very long remissions, or as they finished therapy, trying to guide what to expect in terms of remissions, measuring for residual disease less than that 10 to the minus fourth correlated with patients' remissions. And when you actually looked at by what they received, it didn't really matter what chemo they received to get to the undetectable. The undetectable was MRD associated with the longest periods of disease remissions.
So I understand that after a period when we had BTK inhibitors that produced durability but not depth, with the BCL2 inhibitors, we are now once again seeing a combination of durability and depth. And so this is coming back into focus. So could you just tell us about the initial experience with venetoclax and how it has evolved? We'll discuss a few trials and what MRD showed in these studies. So the first study was, I think, a phase 2 study shown here. Um, uh, and it appears that MRD in this era does predict for the durability. Is that fair?
Yes, exactly. So you're right. The BTK inhibitors can have still disease control, and we don't yet have head-to-head studies saying, that strategy with BTK versus venetoclax, one is better than the other head-to-head to each other. But venetoclax, because of the mechanism of action and the depth of response, then the role of MRD for patients being treated with venetoclax, and again, the same concepts with chemo, predicting how long the remission or response may last for, has definitely come to light more. And then re-ask the question the other way, should it be kind of the target of treatment? In this study for venetoclax following ibrutinib treatment, I think MRD for this group of patients is particularly interesting and important because after ibrutinib or BTK fails patients, especially if they failed because they developed BTK resistance, then outside of trials, venetoclax after BTK resistance is kind of our standard go-to. And so what this study demonstrated is, yes, venetoclax works in that setting, but the way I take away is if you're following these patients, and these are the patients I think MRD is helpful for after BTK resistance, if they don't achieve a deep MRD response, then their overall remission from venetoclax is going to be much shorter than patients that do achieve the depth of response following a BTK inhibitor. And those patients are already, higher risk. We're keeping a closer eye on them. And this is a scenario I think MRD can be helpful for these patients. And so, again, what's demonstrated is that the patients that remain MRD positive, their median PFS is measurable at about 2 years. And so you already want to be thinking ahead of what the next step or plan is for them.
I think this was reinforced by the phase 3 pivotal study, the Murano study, as well in relapse refractory disease. So anything to add as to what this trial showed in terms of the impact of MRD?
Sure. So for Murano, all patients independent of MRD were treated for fixed duration 2 years of venetoclax combined with rituximab. Showed superior PFS of that regimen versus bendamustine and rituximab. But really, in a large randomized study, showed the benefit of patients who did reach undetectable MRD. And as you can see in the relapse refractory setting, those patients had a much longer PFS than those patients that ended the 2 years with a high, greater than 10 to the minus second detectable disease. So I think it really just, confirms that if patients are treated for 2 years, they still have residual measurable disease after venetoclax. Again, thinking ahead that those patients are going to have a shorter PFS.
And it seems like the majority did reach undetectable MRD, if I'm reading this correct. Is that correct?
Yeah, so many patients, or majority, or I should say the minority, were that high level MRD. Most patients were either undetectable or low level positive.
This is obviously encouraging in the relapse refractory setting, but now venetoclax has already moved into the frontline setting for a while. And what can you tell us about some of the experience gained here? I think we can talk about the CLL14 study to just illustrate the point about MRD and its relevance in frontline.
Absolutely. So, as you said, this is a frontline, so patients without previous treatment, and they were randomized either to chemoimmunotherapy or the venetoclax. And in the frontline setting, combined with obinutuzumab, which actually starts for the first cycle before the venetoclax, which is helpful for patients. It helps debulk and lower risk of tumor lysis. And then the venetoclax, when it's given as a first treatment, the way it was approved from the CLL14 is for 12 months of fixed duration. So a year shorter than in how it's approved in the relapse refractory setting. But in terms of what we learned from a MRD perspective, which I think we'll talk a little bit here, again, is similar. Again, these patients, the decision to stop 1 year of treatment wasn't based on MRD. All these patients stopped at 1 year. And so where that stop, the stop at 1 year is patients that were undetectable MRD had a much longer remission than patients that were MRD positive, and not surprisingly, there was higher levels of undetectable MRD with venetoclax regimen than there was with the chemotherapy.
And does the attainment of MRD negativity track with any of the other known prognostic factors? Is it more difficult to get into MRD negativity if you have, say, 17p deletion or some other adverse factors?
Yes, exactly. So I think what we've learned from the follow-up studies is that certain underlying biomarkers, namely historically TP53 aberrations, meaning either a deletion on 17p or a TP53 mutation. Historically, those patients with chemotherapy had a much inferior survival. Fortunately, novel agents have improved that. However, patients with that change are more likely to not achieve a deep response and are more likely to have shortened progression-free survival. So certainly can be one reason, at least in choosing between agents, patients with TP53 aberrations, unless they have a reason not to do a BTK, you might want to favor continuous suppression, for example, because they're less likely with ven-obin to get a deep response. IGHV is a marker that historically with CLL with chemotherapy, IGHV unmutated had much shortened survival response to chemotherapy. With the targeted agents, responses seem pretty equal. So if you look at the left side, the response with IGHV mutated, which is the favorable versus unmutated, about the same. Now the PFS, or the achievement of longer remissions, it's shorter responsive remissions with IGHV unmutated. I would say that difference, though, is still not to the point that I would say IGHV unmutated couldn't still benefit from fixed duration frontline venetoclax. But the big takeaway, I think, is we're all trying to understand how all these markers interplay. And as you can imagine, MRD is probably unlikely to be the only part of the story. So maybe someday we use a combination of MRD and these markers to help make decisions for patients.
So another trend now is to try to combine our two active drug classes, the BTK inhibitors and the BCL2 inhibitors. And would like to see how we're faring so far. These are early days, I understand, in this trial, the CL13 trial. Could you just speak to the audience about what this trial is trying to do, and we'll review the preliminary results in a minute?
Of course. So this is a German study group, 4-arm randomized study comparing various combinations, as you mentioned, of ibrutinib or venetoclax regimens versus chemoimmunotherapy. So patients in the chemoimmunotherapy either got the FCR or BR that we talked about. In the other combination arms, it's interesting because for the venetoclax regimens, how the CLL14 was approved with venetoclax and obinutuzumab. In this study, we see it also compared to the that versus rituximab, which is an important point we'll talk about. And then it also compares it to adding in a BTK inhibitor with ibrutinib, and what is the gain for certainly. We're hopeful that adding things gives better efficacy, but we also have to be mindful that it can give greater toxicity. Patients with CLL are already usually close to age 70 when they're diagnosed, so even older when they need treatment. I think we have to be mindful that really the risk versus benefit is being compared. So this is one of the important head-to-head comparisons of that.
So, and what has the early data shown us?
Yeah, so I think a couple takeaways so far. As you mentioned, it's still early. So what is long-term the benefit from particularly the triple therapy or the BTK plus venetoclax open versus a venetoclax therapy by itself? And I think so far it's kind of early to say that adding in more drugs in a deeper remission is better long-term. For all of them, I think for the concepts, the targeted agents still fare better than the chemoimmunotherapy. But what the second takeaway I would say that's interesting is that venetoclax obinutuzumab was better versus chemoimmunotherapy. But at least so far, there wasn't a significant difference of the venetoclax rituximab. So I'd say the other takeaway many have made on this study is just kind of proving head-to-head that obinutuzumab, like many suspected, is a better antibody paired with venetoclax versus rituximab.
And what do we know about MRD in this study so far?
Yeah, so chemoimmunotherapy has the lowest one taken for all comers. As I mentioned, the venetoclax rituximab, not nearly as powerful as adding in the obin. But the need to wait and see part, I think, is the fact that the triplet, so adding in ibrutinib yet to the venetoclax obinutuzumab arm, it was a little bit more, but not necessarily a lot. And is that worth the added toxicity, cost, everything associated with adding a triplet? I think is too early to see if adding in ibrutinib benefits most patients.
And obviously not included in this trial is just the two-drug regimen of ibrutinib and venetoclax. Would you have a different commentary on that, or that too you would say we need to have justification for still?
Yeah, so there have been, as you mentioned, several different studies looking at ibrutinib, or now they'll be looking at other BTKs combined with venetoclax. I think to say for all comers, it's still early to tell to say. It's certainly not right, I think, for all patients. Patients with favorable risk disease or that might be older, they're probably going to fare well and have less side effects with doing one versus the combination. Ibrutinib plus venetoclax, based on other trials, is not an approved combination in the US, although it's being used in some other countries. But I'd say as a whole, the takeaway is there probably are some patients, like younger, higher risk, where it may help them because they can get a deeper response or less tumor lysis by the time they get to ven. But certainly I think early to say or ever maybe that ibrutinib plus ven is right for all patients.
So obviously we know that MRD is clearly prognostic in a number of these studies now, but the true value of any biomarker is if it can be predictive of planning therapy going forth. So I understand that such moves are afoot. So could you tell us a little bit about the Captivate study and what it is trying to show?
Yeah, absolutely. So the Captivate example of the combination study of ibrutinib plus venetoclax, but asked a couple important questions, and hence then there was also guided randomization steps. So in the MRD-driven cohort, after patients were treated with the ibrutinib venetoclax combination, they were measured for, or they were tested for measurable residual disease or not. And then the two important questions within that is if patients were undetectable, so no detectable CLL, the question is, well, is there any benefit then from continuing the ibrutinib if you're undetectable or stopping therapy? And so that is the undetectable MRD, which essentially showing really not a benefit to continuing treatment if you're undetectable after this combination. Second question was in the detectable MRD. So if you have residual disease at 1 year and therefore continue therapy, is it better to continue the combination or is it at least the same to just continue the monotherapy with ibrutinib? And so that was the question really being asked in the detectable MRD, in which case the combination seemed to push more patients to undetectable and potentially be favorable on those patients with residual disease at the end of the 1 year.
Do we have any preliminary data to share at the moment?
So yes, so that is a great question, and the study has been presented several times in the scenarios I was mentioning, looking in the undetectable, no apparent benefit, at least at follow-up so far, to continuing versus stopping if patients are undetectable. And if they're detectable, then more patients get a greater depth if they're continuing the combination versus the monotherapy.
So we still have to, however, have longer term follow-up to adopt this in clinical practice.
Correct. So ibrutinib plus venetoclax, at least in the US, even based on other randomized studies, is not an approved regimen. So in the US, in terms of strictly based on approvals, is not something we have available. I think the other question, though, is now, when we started our conversation, I mentioned how already on to, of course, second generation covalent BTK like acalabrutinib or zanubrutinib. So now you're almost re-asking this question in the combination studies, meaning, part of the difficulty with ibrutinib was the toxicity, not the efficacy. Maybe, if you're on to the second generation BTK, then that risk benefit of combination therapy is potentially going to shift because you're going to have potentially less toxicity of even the single agent BTK. So when you combine it, presumably also less toxicity than when ibrutinib was combined. In that way, there are frontline studies. For example, the MAGIC study looked at acalabrutinib combinations. I think we'll be seeing more in terms of zanubrutinib combinations. In those cases, yes, definitely too early to report, but I think BTK, BCL2 combinations, who they're right for and how they achieve MRD, and we monitor for that, still have some time to follow up on.
So before we end, just a few questions. Do you routinely test for MRD?
So routinely, no, meaning for the patients on BTK monotherapy, I don't. For patients on venetoclax-based therapy, I think it really depends how you're going to utilize that for a patient. If patient is higher risk or they're getting venetoclax after BTK resistance, then that testing may guide your options for treatment, being prepared, how you monitor patients to capture disease before it really progresses, or in some cases, if they achieve undetectable MRD and they stop fixed duration venetoclax in high-risk patients, you may choose to monitor that way so that you can understand the dynamics of the MRD. Is it starting to go up or or not, and that may guide what to expect for patients, for example. But for patients that are favorable risk, they do their 1-year fixed duration therapy. We see from the CLL14 study, independent MRD, if you just take all comers that got venetoclax obinutuzumab, it's really now only 6-year follow-up or 5 years off of drug where half of patients are relapsing. And so you wouldn't necessarily, utilize that MRD data at the end of fixed duration if you're planning fixed duration 1-year frontline regardless. And so I think it's not yet ready for all patients. I think the second part is the question of how to test, as you went over of the different methods. We and others have an in-house flow-based assay. I think within trials, it's important to understand the NGS testing as well as even deeper responses. But I think we don't really know if every patient, even if you decide to check MRD, that you need to know if it's 10 to the minus fifth or less than 10 to the minus fourth.
And when you do test, do you do it on bone marrow, or are you okay with peripheral blood?
So also great question. The studies would suggest the greatest discrepancy between comparing bone marrow to the peripheral blood occurs when patients have recently, received anti-CD20 antibodies such as obinutuzumab. So especially in the relapse refractory setting, where by the time they finish the 2 years of venetoclax, they're 1.5 years from getting any, antibody therapy, since that's only given the first 6 months. I think the peripheral blood matches pretty closely the bone marrow. In the frontline setting, again, just outside of trials, practicality, most patients don't necessarily want a bone marrow biopsy, but if we really needed to know their depth of response and MRD, then I think we have to be cautious that the peripheral blood at the end of 1 year may show up as undetectable, whereas there's still some residual in the bone marrow. To be strictly speaking, the bone marrow is still the gold standard, but the farther you get out from antibody therapy, the blood and the peripheral blood and the bone marrow MRD are fairly concordant.
I think you've answered the last question for us. So I don't want to keep you here forever. I really appreciate you taking the time to talk to our audience about this emerging area. And I wish, we can talk again in the future when we have more data. And I sincerely appreciate your joining us today.
Thank you very much for having me.
Thank you.